Good afternoon and welcome to today's webinar. Before we begin, I'd like to introduce Kaylani Silk, founder and executive director of Marshallese Youth of Orange County and one of our CAPIWAVES community partners who will open with a cultural blessing.
Good morning, Nines. We are blessed to gather here today to honor our work our diverse community is doing to support and care for one another. In particular, each person's mental health, fueled by the spirits of everlasting love, curiosity, and generosity, we are inspired to unite and share our difficulties and joy.
Thank you. Thank you so much, Kaylani. My name is Nines Ponce, and I'm the director of the UCLA Center for Health Policy Research, professor and Fred W. and Pamela K. Wasserman Endowed Chair in the Department of Health Policy and Management at the UCLA Fielding School of Public Health. As a land-grant institution, we always begin by acknowledging the Gabrielino Tongva peoples as the traditional land caretakers of Tovangar, that is the Los Angeles Basin, where UCLA sits, and the South Channel Islands. Thank you so much for joining us today as we bring researchers and community together to discuss a new report that examines the devastating mental health and economic impacts the COVID-19 pandemic has had on Native Hawaiians and Pacific Islanders in California. If this is your first time attending one of our webinars, welcome. To those of you who have just joined us before, thank you so much for your continued support. As many of you know, the work we're presenting today began in 2020 when NHPI community leaders shared personal stories of the devastating impact of COVID on Native Hawaiians and Pacific Islanders that was being hidden by a lack of disaggregated data. Researchers from across the country came together to scrape the data, develop public dashboards that would provide the evidence used by community advocates, policymakers, the media, and other stakeholders. This project, with support from community and funders, helped us launch the NHPI Data Policy Lab at the UCLA Center for Health Policy Research, which has worked alongside community for the last 5 years to improve data and access to this data. Today, we'll talk about one of those projects which brought researchers at UCLA, UC Irvine, UC Riverside, together with NHPI community leaders and partners to develop the California Pacific Islander Well-Being and COVID-19 Economic Survey, or CAPIWAVES. Known as CAPIWAVES, a survey of 929 NHPI adults and the comprehensive report released last week helps us better understand the mental health and economic impacts of the pandemic of NHPIs in California. I'm so proud of how we all work together. When I think about what we do best at CHPR, it's this special combination of rigorous research and data, community engagement, and informing and advancing policy. I'd like to take a minute to thank some of the people involved in this project. Notably, Dr. Brittany Morey, CAPIWAVES principal investigator, lead author, and an associate professor at the UC Irvine Wen School of Population and Public Health. Karina Penaya, CAPIWAVES data analyst and co-author, and the community engagement and research director for the NHPI Data Policy Lab. And co-authors, Dr. Sora Park-Tanjasiri, Dr. Andri Subika, Cynthia Folk, Shreya Paul, Calvin Chang, the director of NHPI Data Policy Lab, and Alisi Tulua, executive director of the Southern California Pacific Islander Community Response Team, who you will also hear from today. Thank you again to all the community partners who helped us generate data by, about, and for the NHPI population. So to begin, Kelani Silk will talk about the importance of NHPI communities being able to access and use their data. And before I turn things over to Kelani, as always, today's webinar is being recorded and will be posted to our YouTube channel in the coming weeks. If you would like a copy of today's slides, please email our communications department at healthpolicy@ucla.edu, and I'm sure that's already in chat. Again, thank you for joining us today. So let's get started. Kelani?
Thank you, Director Nunez. Before I highlight some of the key points in the importance of having data reporting for our community, there needs to be an understanding of embed or the needs of a community. Data can reveal the disparities or inequalities in a community and help identify groups that need the most help. For example, data on health, access to resources, and or environmental conditions can inform decisions that drive initiatives and inform the community of the results of these initiatives. Okay, so the importance of having data for community is that one, it gives a snapshot of what our community needs are. As a visual community, having reports that provide images such as graphs and charts help our communities digest the information that is being provided. Visual imagery retains the attention of our readers as well. Most of the time, as a community, we are not aware of many of us that are in the same predicament because we are not given an overview of what our status is as a whole when looking at disparities that are hardly ever presented to us. For example, when surveying our local Marshallese community here in Orange County, it came to our realization that the mortality age of our elders was 65. Armed with this information, it allowed us to advocate to lower the age of elderly COVID-19 vaccination from 75 years to 65 when the initial rollout of vaccinations took place. Secondly, this allows us to make informed decisions. Data provides a foundation for evidence-based policy, for program development, and helps to make sure that resources are allocated in a more effective and efficient manner. Furthermore, we as a community, we're also able to identify different trends, patterns, or gaps in service providers to our communities, which can lead to more targeted and impactful interventions. So, as a kid raised in the 80s and 90s, the youth at that time knew that many of us opted out for secondary education so that we could join the workforce and help our parents take over caring for the house or our younger siblings as they went off to work. This was because we didn't have the support we needed that was both culturally cognizant and in language, and one that could alleviate us from our daily household responsibilities and or shared financial burdens. The third point I'd like to speak on is how we can allocate resources based on report results. Now, data helps us determine what areas need the most resources so that we can direct funding and services to those areas to ensure we are making the most impact. This can include infrastructure needs that can inform decision making that directly affect our people, such as health, immigration, climate, policies, and much, much more. That can make, of course, the most impact. So my OC did a survey when we visited a community event that had Marshallese youth participants from different regions in California and found that substance abuse was more prevalent in Northern California versus here in OC. This matters because we were then able to create programs based around those results of the surveys and funnel more funding towards programming that were geared towards substance abuse to the northern regions versus us here in the South. Data also places accountability, and it also supports advocacy. Data can be used to hold our leaders, our policymakers, and organizations accountable. It can provide evidence to our communities on the effectiveness of our programs, and it can aid in advocating for better services and policies. So, for example, during the height of the COVID-19 pandemic, there was an influx of calls into our NHPI organizations for interpretation and translation services. There was a real need for capacity building in order to assist the many calls that came in, and many of them had opted out to seek assistance for themselves or not seek services at all. We have since created an NHPI language task force to write policy to address these areas. And advocacy for data disaggregation and accountability continues as we find discrepancies and or lack thereof within various databases that we've had access to, where we've also made queries out of. So data helps build capacity. Data reporting helps build capacity. Data literacy can provide new revenue streams. It can allow for self-governance and sustainability, and it empowers the community to build their own capacity. This is most evident in our organization, the Marshallese Youth of Orange County, where based off of truancy rates and the turnaround for those that are moving on to higher education, we found that as first generations that were born here in California, we had to forego that to help our parents. But we also noticed that the second generation that were born in California were continuing on with that trend. And so this led to the formation of the Marshallese Youth of Orange County to kind of alleviate and work as a surrogate family for our second, third, and fourth generation youth, so that we could mediate those the critical needs of one's family. We could provide after school programs and guide them in their journey of higher education, and also assist our elders and our family members when it comes to language and interpretation. And finally, data allows us, continued data and continued reporting allows us to track our progress. It gives us the continued opportunity to address gaps. It allows us to make modifications to our programs and gives evidence-based results that will enable us to further fortify our advocacy work, so that we may build future ambassadors for our people that will carry our language, traditions, and culture, ones that can integrate seamlessly into different social settings, mediate their own needs, address disparities, and sustain fortified infrastructures so that we not only survive, but we thrive. Como dada, and thank you so much. Now, I'd like to turn it over to Dr. Brittany Morey, Associate Professor of Health, Society, and Behavior at UCLA Irvine, and Principal Investigators of CAPIWAVES, and lead author of the report.
Thank you so much, Keilani, and for the amazing work that you do with MyOC. I also want to take a time to recognize that what we're reporting on today, the CAPIWAVES project, was touched by many different hands, including our co-authors, the reviewers, and many other people who made this report and this webinar possible. And especially I want to highlight our community partners who are with us from the beginning, including Kelani from MyOC, but all these others that I'm listing here. These community partners were integral to the success of CAPIWAVES, and many of you are here today. And so I would like to extend a warm thank you and to say that we are here to celebrate this release of this current data. I also want to recognize our funder, the California Collaborative for Public Health Research. The purpose of CAPIWAVES was to illuminate the mental health and socioeconomic impact of COVID-19 on California's Native Hawaiian and Pacific Islander population in response to the community's desire for these data. Now, CAPIWAVES we collected data, and the survey design that we used was called Respondent-Driven Sampling, or RDS. And we used RDS to conduct an online survey. Native Hawaiian or Pacific Islander adults, 18 years and older, who were living in California at the time, were eligible to participate in the CAPIWAVES project. We collected data from January to May 2024 with questions on mental health, socioeconomic status, and more. Thanks to our community partners, we were pleased to be able to offer the survey in both English and Marshallese languages. And so we were so thrilled when we were able to collect a relatively large data set of 929 NHPI adults in California through this CAPIWAVES effort. A little bit more on the respondent-driven sampling method. This method would not have been successful without intensive community engagement throughout the entire process. Through community partnership, we were able to work with our partners to identify 60 seeds or initial survey takers who represented the 6 largest NHPI groups in California: Chamorro, Fijian, Marshallese, Native Hawaiian, Samoan, and Tongan, in northern, central, and southern California. Once the seeds took the survey, they received 4 codes to be able to refer 4 other NHPI family members and friends. And those referrals became our Wave 1. Once they took the survey, they also received codes to be able to keep the survey passing on, and therefore the waves were able to grow. And we're happy to report that we were able to reach 12 waves of data collection. Now, because our community partners were with us and engaged throughout the process, from the formation of the questions and the proposal to interpreting the data, it's only right that we spend time to report these data back to the community. And that's what we did in June 2024. We presented our initial findings back to the community in a webinar similar to this one. Since then, we've been working closely with our community partners to continue to analyze the data, to put together some beautiful tables and visuals, and to develop recommendations based on the data. And so today we're happy to announce the release of the report on mental health and socioeconomic impacts of the pandemic on NHPIs in California. There are several successes or wins that I can highlight from CAPIWAVES. One is that by allowing survey takers to receive additional gift cards for their referrals, they were incentivized to be able to keep the waves passing on. And recruitment was supported by the tireless efforts of our community partners through being our cheerleaders in the community and continuously following up with their folks to make sure that the waves continue to grow. And because of our community partners, we can say that as far as we know, this is the first successful RDS sample of NHPIs in California to produce the largest survey that we know of mental health for NHPI adults in the state. And so this effort demonstrates that through effective community engagement, we can collect data in a timely manner and report that data back to communities, and that this data these methods can also inform other efforts, not only for NHPIs, but for other small and minoritized populations. These are some of this is a snapshot of the report that we're releasing, and it includes infographics that are also in the report. So one note on how we constructed and report NHPI race categories through CAPIWAVES. Survey participants were asked to report their race and ethnicity, and they reported Pacific Islander and/or any of the other Office of Management and Budget race groups. Once people selected Pacific Islander, they were further asked to specify their detailed NHPI race listed here, including a category for other Pacific Islander in which people were able to write in and specify the NHPI race that they identify with. These data were then taken and reported out in the report as 7 NHPI groups that we were able to disaggregate: Chamorro, Fijian, Marshallese, Native Hawaiian, Samoan, Tongan, and other Pacific Islander. It's important to note that multiracial NHPIs were included in each of these groups. Respondents were allowed to select multiple race and ethnicities as well as multiple detailed NHPI race groups. And so then their numbers are counted in each. For example, someone who reported that they are both Marshallese and Native Hawaiian, their numbers would appear in both the Marshallese counts as well as the Native Hawaiian counts. So that if we were to add together all the people in each of the 7 groups, that sum would exceed the sample size of 929 because people could be counted in multiple different groups. So please keep that in mind as we move forward. And now I would like to introduce Shreya Paul, a research data manager for the NHPI Data Policy Lab, who will walk you through the data analysis and interpretation and share some of the findings from the CAPIWAVES report.
Thank you for the introduction, Brittany. It's my pleasure to present on the methodology and interpretation of the CAPIWAVES report. So starting with the analysis method, so for this analysis, we used RDS Analyst version 0.71, which is a graphical data analysis software powered by R programming. The weighing method that we used for this analysis is Guile Successive Sampling Estimator, and it uses the respondent's self-reported network size to calculate sample weights. And using the software and weighing method, we calculated the percentages and the 95% confidence intervals of all the questions that were asked in the CAPIWAVES survey. Next slide, please. So data interpretation. The first thing I want to point out about data interpretation is that we cannot use the CAPIWAVES report to compare detailed NHPI groups. Overlapping 95% confidence intervals indicate no statistically significant difference, and I will explain this with the help of a table in the next few slides. Unreliable estimates are marked with an exclamation mark, and so use extreme caution when interpreting numbers with exclamation mark. Not recommended for planning, policy, or advocacy decisions. We have presented all data for completeness, but please focus on stable estimates, that is, estimates which do not have the exclamation mark. Next slide. So in this slide, I present one of the tables, that is table 8 of the CAPIWAVES report, which asked about delayed or did not receive mental health care question. The question had 3 response options. The first one, didn't want care. The second, wanted care, received it. And third, wanted care but delayed or did not receive it. And you can see these options in the columns. The rows represent the NHPI groups, and each cell of the table represent percentage response and 95% confidence interval. Next. As you may see that some estimates are marked with an exclamation mark, so these are unreliable estimates, and we should exercise caution when interpreting these estimates. Next. So the first suggestion that I have for interpreting the table is that do not compare across NHPI groups. For example, using this table, we cannot say that a higher percentage of Chamorros than Fijians didn't want care. Focus on reliable percentages and pay attention to warning markers. Next slide. Before diving into the findings of the report, I want to highlight the key demographic characteristics of our sample. Our sample size was 929. So a higher percentage of our sample was Samoan and Tongan. 62% or a majority of our sample were women, 34% were men. 37% of our sample belonged to the age group 20 to 29 years. 31% of our sample belonged to the age group 30 to 39 years. And 81% of our sample indicated that the sexual orientation is straight. A majority of a sample indicated that their annual household income was less than $20,000, and 18% of our sample indicated that their annual household income was between $20,000 and $39,999. A majority of our sample were high school graduate, that is 41%, and 28% of our sample indicated that they had gone to some college. Next. 66% of our sample had health insurance, and 35% of our sample came from Greater Bay Area, and 26% of our sample came from other Southern California. So in the next few slides, I'll be talking about some of the findings from the report, and these findings, we have created an infographic with these findings. So the first one, more than 1 in 4 experience fair or poor mental health. 1 in 3 reported needing mental health care for help with stress, depression, or emotions in the past year. 24.1% reported moderate or severe anxiety. 7% reported major depressive disorder. Access to mental health care. Nearly 3 in 4 reported never seeking professional help for emotional or mental health problems. 1 in 6 reported avoiding or delaying needed mental health care. And our report also found the top 3 reasons for delaying care. The first one being cost, money, or lack of insurance. The second one, not knowing how to find a mental health provider. And the third one, not wanting friends or family to find out. We also have an infographic on the economic impact of COVID-19 on NHPI adults. And in that we see 1 in 3 of NHPI adults had a decrease in household income since the pandemic. 29.7% of NHPI adults had someone in their household lose their job or a significant amount of their income as a result of the pandemic. And financial and childcare difficulties due to COVID-19, more than 1 in 4 NHPI adults had difficulty with basic financial necessities such as paying bills, tuition, or affording groceries. 1 in 4 had difficulty with paying rent or mortgage, and more than 1 in 9 had difficulty obtaining childcare or had an increase in childcare expenses. We also have information available about access to financial assistance during the pandemic. For example, among all NHPI adults, 19% received government health benefits, including Medi-Cal, Medicaid, and Medicare. We also have information about what percentage of NHPI adults who were eligible got these financial assistance. For example, 31.2% of NHPI adults who were eligible based on reported household income received government health benefits. 19.4% received support through CalFresh Supplemental Nutrition Assistance Program or SNAP. And 31.5% of NHPI adults who were eligible based on reported household income received CalFresh or SNAP. 6.7% of NHPI adults received Earned Income Tax Credit or EITC. 14.7% of NHPI adults who were eligible based on income and being a parent received the EITC. 5.7% received CalVERS or temporary assistance for needy families or TAMF. So similarly, we have other estimates available on the financial assistance NHPI adults received during the pandemic. And I invite you to explore our report and infographics to go through these statistics. Next slide. So what else is in the report? We have many other estimates on mental health. For example, satisfaction with mental health care, COVID-19 related mental health, alcohol and substance use. Estimates are available on economic well-being such as occupation, job changes, receipt and use of COVID-19 stimulus checks. Our report also consists of other details such as acknowledgements, backgrounds, methodological details, key term definitions, and cited works. And finally, using our statistics, we provide some recommendations such as on mental health and economic programs, policies, and future research. So what's next for this data? I'd like to welcome one of our community partners, Alici Tulua, Executive Director of the Southern California Pacific Islander Community Response Team, who will talk about how NHPI communities are planning to use the data. Thank you.
Thank you so much, Shreya, and also want to say thank you to everyone that's spoken before me, Dr. Nunez Ponce, Brittany Mori, and of course, my sister in this work, Kalani Silk. I'm excited for the opportunity to share this report with the community, and I hope that you've gained a little bit of insight to the wonderful data that is in this report, and that this is something that can be useful to you. So I'm going to be talking a little bit about some of the recommendations that came out of the data that was gathered and some of the reflections with community partners, as well as the next steps, which basically are to take on the recommendations and then work further to deepen our knowledge around mental health and economic disparities for our community, as well as building the infrastructure to respond to the needs that are identified by the data. And so some of the recommendations that were developed out of the data that was gathered here, I think many of you that are here probably already know a lot of this information, but we hope that what is presented in the report in terms of the data will help us move forward on some of these recommendations more easily than we've done before. Before I dive into this, I just also want to pay my respects to everyone that's here, each and every one of you, for spending time here. I know how important this is to our work, and so I appreciate you being here, and as well as some of our elders that are in the webinar, for the foundation that you've laid for us to be able to do this work. I know that many of our elders, some that are not even in this webinar, have worked tirelessly for decades to destigmatize mental health within our communities. There's been just a lot of work. And what the pandemic did was amplify this issue for our community. And so our responsibility as community leaders and organizations is to act upon what we learned during the pandemic. And what the pandemic amplified, we knew already existed for our community. And what this research is doing is helping us to quantify what we already knew existed in our community. And so I just want to recognize many of our elders, particularly those that are in Northern California, who have had more access to funding to be able to do mental health work. And our Southern California community organizations are also following your lead and hoping that we can move together across the state and even beyond California. So one of the first recommendations that came up is the need for more culturally appropriate, even linguistically relevant mental health programs. What's one thing that I know for me in our work with SoCal Pickard that we identified during the pandemic was the lack of mental health programs within our own organizations, but also for example, community health clinics that exist around us, there aren't too many culturally appropriate mental health services or programs. And so this report and the data will help us to advocate for mental health programs specifically for our population, as well as partner with other organizations that already do mental health work, that are already receiving resources to provide mental health programs, to be able to create space for our communities and their needs. Another recommendation is around mental health policies. And these are policies that can help lessen the financial and insurance barriers for NHPIs that are seeking care. As you saw in some of the data that was highlighted, I think we can all relate to the connection between financial distress and the mental health impact on our communities. And so this report and the data will help us to advocate and move some of these policies that can help both areas for our community. I know one thing that we saw shortly coming out of the pandemic is there have already been decisions at the state level that exclude our community in funding specifically around mental health. Our community, we were surprised to see, for example, a request for proposal for funding for mental health programs that did not prioritize our population. And so both Asian American and Pacific Islander communities were not listed as a priority population in this RFP. And so we already see that there is a lot of work for us to be able to advocate for policies that include our communities, given what the data says about where we are as a community. Thirdly, we want to continue to do mental health research. We're really excited with this data, but this is one step forward, and there's so much more to understand about our community around mental health, as well as economic disparities. And this includes both qualitative and quantitative research. We know how both go hand in hand for our community. And this can help further the work in addressing mental health and economic disparities. We also are recommending to evaluate mental health interventions that exist. Many times when we have to, for example, apply for a grant that cites best practices, many best practices do not include work for our community. And so there's a recommendation to be able to evaluate, to continue mental health research that evaluates the different kinds of interventions that help mental health areas in our community. A lot of this programming already exists in many of our organizations that do cultural programming, language-centered programming, and we know how important that is to especially our generations that are born and raised in this country, being a little bit more disconnected around cultural identity. But these programs exist, and we hope that there will be more work around research to evaluate the impact of these kinds of programs on the mental health of our community. Next slide. As I said before, aside from mental health programs, continuing to build community programs that educate and share information about our community, and not just within our NHPI community, not just education within our community, but also education for our partners, county agencies, to be able to understand how to connect with our communities to provide resources that can support them. This can also support community-based organizations and community health navigators who help to connect our community to services outside of our organizations. There's a recommendation for continued partnerships between NHPI organizations and community health workers with local agencies to just better leverage the resources that already exist within our counties, within our state, to be able to bring those resources closer to our communities. there's a recommendation to increase, also increasing language access to information and enrollment in government assistance programs. Language access is an area that many of our organizations are working around, and especially for a population like ours that is much smaller. Oftentimes we don't have the data to be able to advocate for language for services or information to be provided in our many languages. And so this work can continue to further our efforts around language access. Last but not least is a recommendations for policies that require assistance programs to be fairly and equitably benefit populations like ours who face disproportionately negative impacts on health and welfare, especially during public health emergencies. So these recommendations are based on the work that that went into CAPIWAVES, and as a community-based organization, this is a tool that can help us advocate for policies, advocate for resources to be able to help our communities, but also to strengthen and build better relationships with research institutions, government agencies that have programs and resources to assist our community. And given the current state of our economy and of our country, this is a tool that can help us, that can help inform the work that we're doing. We know that mental health was severely impacted in our community due to the losses that we suffered during the pandemic. And so this research program came out of our need to have data to be able to advocate for work that can be done to help build a thriving community. So together, I know that we can do that, not just as community-based organizations, but also alongside our community and alongside our partners, such as the researchers that have conducted this work and each other. So thank you very much. And I look forward to much more work ahead. As the saying goes, the reward for good work is more work. With that, I would like to open it up for any questions that you all might have, and I'll facilitate a Q&A here before we close out. All right, so I invite all of our speakers here, if you can please come on camera, and I'll put out some of these questions for each of you. And if you're able to answer it, go ahead, and if have additional thoughts, that would be great. So first question is it possible to receive regional breakdowns for some of the data? Brittany.
Yes, it's definitely possible. We're happy to take requests like that and to break down the data accordingly, and to have those regional reports. So please do reach out to us. We have all these data. We would love for it to be useful, the most useful as possible for communities.
Thank you, Brittany. I'll read this. Let's see. Thank you for sharing this great resource. Would it be feasible to share some general budgetary parameters with interested community organizations that are working on data collection improvements with our public health agencies? I don't know who's taking
I think there's a follow-up comment from Jake that it doesn't have to be shared here, but maybe what would be useful, Brittany, is or at least see about how much was provided to the participants. I think that would be like a starting point.
Yes, so participants were able to receive $30 for completing the survey. The survey was pretty extensive, but I would say on average it took about 15 minutes for people to complete. And then for each referral, up to 4, people could receive $15 additional for each of those referrals. And so if someone took the survey themselves and then 4 of their referrals all took the survey as well, or at least started the survey, then they could receive up to $90 in gift cards. And so we wanted to make sure to fairly compensate community members, but also we didn't want to be overly coercive in that as well. So there's a balance. But we, after much debate, kind of landed on those amounts so that we could try to, make sure that the waves kept going and that people, that people would feel fairly compensated.
So Jake, we can meet with you, but I think why CAPIWAVES was successful was because of the time spent with explaining what it is. So it is respondent-driven survey sampling with a lot of love, care, and effort from the team. And it is, I think that's what allowed it to grow through 8 waves. And so I think that's the part that's also you have to think about in creating a budget, but also you need to, I think the takeaway from this webinar is that it was fueled by community. It would not have happened if there weren't community ties. So that's, I think, the part that the compensation for communities, but also the bridging part and the explaining part, the time it took, also should be considered in a budget.
I just want to add quickly on the side of the budget that we're happy to talk with you again more in detail, but we also did our best to compensate our main community partners who are really the cheerleaders in the community for their time, for continuing to be those cheerleaders and identifying the initial seeds and then making sure that the waves kept progressing. And so we did make sure to try to honor their time and their efforts.
Thank you both for those great answers. Another set of questions, I'll ask it all at the same time. What are some of the best strategies to collecting data from this population, including days, times, ways of data collection? Were there any difficulties? Any specific age groups? I know that you shared earlier that it was adults, 18 and over. So you want to answer that, Brittany?
Sure. So I think because it was an online survey and, people are kind of used to doing these things, they could do it on their phone as well as, any other computer or iPad or device. But because of that, I think maybe some of the elders might have had a little bit difficulty if they weren't used to navigating on a device like that. And so we did see more young people taking the survey, especially initially. And as the waves continued, we encouraged people, invite your other family members. And I think through our community partners, many of them kind of got that word out. And we heard some stories from the field of family members helping their elders to complete the survey. So assisting them in the home with filling it out and passing on the codes that we gave them. And so it really was, I think, those efforts in the community that helped the waves to continue to grow. And so we heard a lot of those types of stories. But it was challenging. We didn't have an automated system to, for example, deliver the gift cards to everyone or an automated tracking system. So that was a team of 3 of us who were checking the survey every day, seeing who completed it, manually going and sending the gift cards to people, and then tracking how the waves grew over time. And so that was a lot of labor of love, but we wanted to make sure that the waves continue to grow. And because of that, we were able to do it in a relatively short time span. But in the future, I think we would figure out some better automation for that process.
Thanks, Brittany. I was also surprised to see that we reached 12 waves because I think our goal was if we could get to 6, then that would feel successful. So it was, like, as Brittany said, a lot of intentional and loving energy. Here's another really great question. How can we compare the results with the general population and or other races? So to show the inequities experienced by the PI community. So for example, what was the prevalence of wanted care but delayed or did not receive among whites? As an example.
Maybe Ninez can chime in here, but I think a lot of the mental health questions, we tried to structure them similar as other surveys, including the California Health Interview Survey. That said, the data are not directly comparable in that, the method of data collection for the California Health Interview Survey is very different than what we did through respondent-driven sampling in CAPIWAVES. That said, I think that, given the limitations of, not being able to do like the full random sampling that normally happens in something like CHIS, that CAPIWAVES, we say that it's quasi-population representative or tries to get at as much representation as we can by taking into account people's social networks in the ways that we weighted the data. And so we can kind of use the numbers and kind of hold them side by side, perhaps to maybe some estimates that we could generate from a tool like AskChiz and kind of see how that generally compares. But there's not like a statistical test that we can say these are significant differences, but I think we can at least kind of qualitatively look at the numbers and see how it compares.
Yeah, the representation piece was addressed by Brittany, but I recall a colleague of mine from PCORI who ran the disparities set of programs where she said, when you talk about inequities, it doesn't necessarily always have to be comparative. I think focusing on one population and looking at the heterogeneity of needs within a population, heterogeneity because of subgroups, that's why we need disaggregated data across age groups, across geographies, that is already instructive about uncovering health inequities. So, so to get away from the disparities, which is this versus the other, and having a comparative group. So I think that's one comment I have. The beauty and value of CAPIWAVES is it focuses on a large sample of Native Hawaiians and Pacific Islanders. It's approaching some representatives. It's not a probability-based sample, but it does uncover a lot of the experiences and stories of the vast differences across within the Native Hawaiian Pacific Islander population. So I think that's the value of that. Agree, we can look at AskCHIS or look at the census to get a population representative data, but as long as we know that and acknowledge that it's not exactly all probability, but then we understand then what segments of the population are represented, then I think that is a service to creating knowledge on evidence for policy for this population.
Thank you both for those answers. What are topics that you think need additional research and examination to aid NHPI communities?
Maybe we can ask Kelani. Is Kelani still on? Maybe we should hear first from the community. And you, Elise.
Yes, my apologies. Elise, can you repeat that question for me, please?
Sure. What are topics that you think need additional research for our communities?
Well, I mean, mental health, honestly, I can't say enough about mental health as far as research goes for our communities. And I definitely would love to see more disaggregated data for our communities when looking into for myself when I'm trying to do research and I'm trying to find out ways to assist our family members here in OC. I find it hard to find data, so it's very sporadic. And when I'm looking at health disparities, I would really love to see more focus in on our mental health, especially for our youth that are coming up, that have lived through the pandemic. We're finding more that, coming out of the pandemic, anxiety has been one of the main focuses that we're looking at nowadays, because they've been so that cabinet fever of being home for such a long period of time and coming out of it and trying to kind of re-socialize and reintegrate with one another. It's been a challenge for us here, throughout, actually nationwide. So I would really love to really build that up. Yes, thank you.
Thank you so much, Kehlani. I think you've answered for both of us. That's probably another interest is how our younger generation has fared since the pandemic and the implications of it for the future that they're facing. So that probably is top of mind right now. Thank you so much, and thank you everyone for your questions. I know I didn't get to all of them, but to make sure that you get back to your lives, I want to thank you all for being here, and I want to hand it back to Brittany, who we're so grateful for. I can express that, but I want to say thank you again, Brittany, to you and the team here, and to Ninez for your leadership and for carrying this work for our community, and we look forward to continued work. And I hand it back to you to close it out. Thank you.
Thank you, Elise. And thank you to Kehlani and all of the community partners who helped to make this report possible. And so we're going to end today's webinar with a closing blessing. So I'm going to hand it back to Elise Tulua to do that.
Thank you. And let's bless the rest of your day. Thank you to everyone, and blessings to all of us for being here and growing together. And as we leave, we will take what we have learned and continue sharing the knowledge and blessings with all of our families, friends, and loved ones. We're grateful to be able to spread the knowledge that we have collectively built through this project. And we wish you to go now in peace. Have a wonderful day.